Well, this is the only methodological slide that I brought for today's discussion, summarizing the target analyte, the samples that can be tested, and the main advantages as well as main limitations of probably the 4 standard methods that are being used today to assess treatment efficacy. That is mass spectrometry, NGF, NGS, and PET-CT. And I would say, and I would focus mainly on the main advantages of these 4 methods. Obviously, mass spectrometry, it sees minimally invasive nature. For flow, the fact that it is not required a baseline sample. NGS, the fact that it can be performed using frozen samples. And this has been paramount, particularly in large multi-center clinical trials, and obviously with PET-CT, the assessment of extramedullary disease. And my question is whether or not the panel agrees that myeloma is at the forefront of innovative methods for response assessment, and if we need other methods, and if so, what could these be? For example, soluble BCMA. Another important question is whether or not myeloma is ready for minimally invasive monitoring. And to propose this question to the forum and to brainstorm, I shared here an hypothetical scenario of a 3-4 year course of treatment in a patient in whom, after the first year of treatment, MRD is assessed in the marrow. We do believe that this is probably the best sample during the first year of treatment, because it's usually where highest efficacy is achieved, minimal tumor burden, and probably the blood will not be sensitive enough. And even for the mass spec, at very early cycles, that might be the issue of the long half-life of immunoglobulins. And also the assessment of MRD in the marrow during the first 9 to 12 months is very much aligned with the endpoint definition that was proposed and endorsed by the FDA. Then thereafter, there could be confirmation of sustained or unsustained undetectable MRD in the marrow with tailored periodicity according to patient characteristics and willingness patient, then to perform assessment of peripheral residual disease or PRD, for example, every 6 months. And this could be used, this can be performed using mass spec and eventually flow or sequencing technologies. Ideally, the same method that has been performed in the bone marrow. And obviously not forgetting the value of PET-CT, particularly in those patients that show at baseline extramedullary disease or are at high risk of developing extramedullary disease. Well, in this slide, you can see an estimation of the relative 5-year overall survival based on the year of diagnosis and how this has evolved with new treatment paradigms, and also how these new treatment paradigms have impacted the cumulative undetectable MRD rates. And I think that by looking at this slide and these estimations, I think that it is fair to say that there is a clear relationship between efficacy, durable MRD, and survival outcomes in multiple myeloma. And one thing that I would like to stress out is the fact that with each new class of drugs that has been developed and approved for the treatment of myeloma, the MRD negative rates are going higher and higher, despite the fact that decade after decade, we have developed more sensitive tests to assess MRD. I think this speaks out to the potency and efficacy of the new regimens. Therefore, this brings us to the concept of using MRD as an endpoint because of that strong relationship between rates and durability of MRD responses with patient survival. And obviously, I will not describe the data of the meta-analyses that were conducted for the approval of MRD as an early endpoint for a potential approval of new drugs in myeloma. I would rather focus on some of the advantages of using MRD as an endpoint. And in my view, beyond facilitating clinical trial design and eventually having drugs available earlier to patients, is a possibility to learn in real time what is the potential benefit of a new schema. And here I present two MRD negative rates at 10 to the minus 5 on the intent to treat patient population in two different clinical trials. On the left, Cassiopeia, this is after induction, 34.6%, and very recently data from the French myeloma group, the MIRAS trial, as you all know, with probably the highest MRD negative rate ever achieved after induction with ISA-KRD, 63%. So without knowing what will be the PFS in this trial, we already have a flavor of what was the benefit in terms of induction from one study to the other. Another important point is the fact that we can learn also in real time based on MRD negative rates within a single study who are the patients that are benefiting the most versus those that are not benefiting that much from this regimen. And this, for example, can be observed regarding cytogenetics in the MIRAS trial. And apparently, the MRD negative rates are quite high and equally high for patients with standard and high-risk disease, but when dissecting according to specific cytogenetic alterations, you can see that there is a drop in those patients with 11-14 translocation, as well as those with a 17p deletion. Now I have a few slides with the text that I will basically read as points for this is an estimation of what future trials may look like. If we now assume, and this is mainly based on Perseus, that the 4-year PFS for newly diagnosed myeloma transplant eligible is approximately 85%, and the target hazard ratio for PFS for a novel therapy versus that standard of care would be, for example, 0.7, which is not dramatically high, then a 2-arm trial would require more than 300 total PFS events to have a 90% power to its final analysis. And this requires a sample size of almost 1,000 patients and minimum 7 years for an early readout, an interim analysis that would not be fully powered for PFS, and 12 years for the fully powered final analysis for PFS. Now, at a typical trial accrual rate of 30 patients per month, the study would take approximately 3 years for enrollment. This means approximately 4 years till you have the last patient being assessed for MRD after 12 months of therapy, meaning that the MRD endpoint would be available in 4 years' time after trial initiation. This would be at least 3 years early, if not 7, before the PFS readout. And in terms of the balance between benefit coming from efficacy and risk regarding toxicity, there would be considerable amounts of toxicity data available during that 4-year period. These are ideas about using MRD endpoints in clinical trials to establish early on whether or not two different therapies produce the same benefit in terms of MRD negative rates is equally important to prevent false expectations and reduce the development costs of ineffective treatments, particularly for the companies. Other possible application is to design trials thinking on improving patients' quality of life. That is, to show non-inferior MRD negative rates and therefore expect a similar long-term PFS with probably less intensive or a shorter duration treatment approach. And then the issue of patient crossover. This would not modify dramatically the issues regarding those trials with patient crossover. But I think that having PFS and MRD negative CR as, for example, as co-primary endpoints may facilitate the use of patient crossover, provide greater confidence on the benefit of OS, even if this cannot be demonstrated in such a trial because of patient crossover. And I end up this slide by asking other thoughts about using MRD as an endpoint for the discussion. Again, mainly conceptual slides, hypothetical scenarios, And this is a conceptual slide with an hypothetical scenario about fixed treatment duration in patients with sustained undetected MRD. And this is a patient in which after treatment initiation, MRD negative CR was achieved during the first year. This MRD negative CR was confirmed 2 years after, and because the patient was in a deep remission and there were no red flags of potential unsustained MRD negative response, treatment was stopped. And thereafter there was monitoring of disease in the marrow and in the peripheral blood or serum, probably using that schema that I showed in a previous slide. And because we know that MRD negative CR does not mean cure, obviously there is the possibility of disease progression, and before that MRD and or PRD resurgence. And whether or not this can be used to resume treatment before clinical progression is being investigated in ongoing clinical trials. And I have here 4 bullet points for discussion about whether such a scenario could lead to improved quality of life and reduce cumulative toxicity owing to treatment-free interval. At the time of relapse, the disease is probably non-refractory to the previous regimen with a very long washout period. And obviously patients were exposed to certain drugs, but because of that long washout period, maybe there is greater sensitivity of disease to salvage therapy at MRD resurgence. And I asked the panel if this is realistic, and if not, what additional evidence is needed. Okay, we are heading towards the end of my presentation. These are additional bullet points for discussion. Typical arguments against the use of MRD, why assess it if patients with undetected MRD may relapse, the fact that a few patients who test positive experience nonetheless long-term survival, why to assess MRD if there are no guidelines on how to use it for tailored treatment approaches, obviously the need of multiple bone marrow aspirates, particularly in the frail and elderly patients, and this is also a recurrent argument, the lack of reproducibility between MRD results in clinical trials versus routine practice, quite the opposite that Paul was alluding before in his presentation. And this is my personal overview about MRD assessment in myeloma. Challenges remain. I think we still need a greater implementation and standardization of assays for MRD assessment in routine clinical practice. Reimbursement is an issue in some countries and areas of the world, and we still need increasing expertise in performing MRD tests and interpreting the results, for example, regarding the sample that is being used, time points, and the methods. Also, there are controversies that remain. One for sure, how much representative is a single MRD assessment of the overall tumor burden? The prognostic value of MRD in specific patient subgroups, for example, those with high-risk cytogenetics, this for me is still an open question, and the role of MRD in guiding therapeutic decisions in routine practice. And hopefully, some of these controversies, the last one, can be clarified in the next 5 to 7 years with the readout of ongoing clinical trials. There were some key milestones, for example, the development of the MRD response criteria by the IMWG back in 2016 that will be probably updated this year. The generation of high quality and standardized MRD data in clinical trials after the development of the response criteria that was paramount for the acceptance of MRD negative CR as a surrogate endpoint for accelerated assessment of treatment efficacy or standardized MRD assessment. It's still the time to assemble large clinical trial and particularly real-world data sets to inform on the best use of MRD. And like I said in previous slides, now it's the time to implement innovative clinical trial design using the MRD negative CR endpoint by saying that there is no precision medicine without precision diagnostics. Obviously, MRD should not be used as a single parameter rather in the context of other prognostic factors and patient characteristics. But I do believe that the fact that usually MRD is a strong, if not the strongest prognostic factor, is the fact that a single assessment, to some extent, crystallizes all the patient characteristics in terms of tumor biology, disease dissemination, performance status, and even tolerability and adhesion to the proposed treatment. I'll stop here. Thank you for your attention.
I have a question and a remark. So you very elegantly showed that whenever you have a MRD negativity increase of 10%, your hazard ratio for PFS is 0.7. And I think it would be very interesting to have those data also available for sustained MRD negativity, because I think especially in the high-risk patients, it will be very crucial to have sustained MRD negativity. So are you or others planning such analyses in order to bring this further, and also then design the trials maybe differently as compared to now looking at fixed duration after really even more sustained MRD negativity maybe? That was the question, and then later one remark.
Thank you, Sonia. That is a very, very important and valuable question. I must say that by the time we performed those analyses, that was not on our minds, mainly because the amount of data available regarding sustained MRD negative rates was not as high as the best MRD response rate that has been typically published in all phase 3 randomized trials in the past 10 years. Only more recently, we are seeing also the report of sustained MRD negative rates at 12 and 24 and even 36 months. So I think that we need to revisit that. We need to perform those analyses. Probably by the time we have, again, another 15, 20 clinical trials with that readout to have an estimate of how much you need to gain a clinically meaningful benefit in terms of PFS and eventually OS. But I do believe it's a very important endpoint. For example, and again, to highlight how there are still a lot of open questions. A delta in MRD negative rates may be very useful for randomized clinical trials, but the MRD endpoint can also be used for single-arm studies, for example, in relapse refractory.
I already see other hands, but my remark was that maybe with the fixed duration studies, we may want to exclude the patients with high risk because of the analyses of Luciana Costa showing that for the especially double hits, it does not account. So I think we should maybe do then different clinical trials for the high risk for fixed durations and the non-high risk. I would consider that at least.
Yeah. Thank you, Sonia. I want to echo that actually, because I just wanted to pivot to sort of ongoing designs that are currently out there. In determination 2, we have an MRD primary endpoint, which is critical to getting our sample size to a manageable level. And to your point, Bruno, for our standard risk MRD negative patients in whom we spare them from high dose intensification, we're looking at a second randomization of MRD negativity after 3 years of maintenance, then being randomized to just CELMoD alone versus observation with exactly the goals that you laid out so nicely. So I really wanted to echo your call to action in terms of clinical trials, recognizing all the challenges of MRD use in real world practice. And I think Sonia's spot on about high risk, where MRD may be actually particularly valuable, whereas interestingly in standard risk, I think it's a very interesting question because you touched on this construct that there are a number of patients who are MRD positive who have survivorships that, you know, are measurable in 5 to 10 years at least, if not longer. And the question really is, in that standard risk group, can we continue to use MRD to better understand what that subgroup really means? So I think it's an incredibly important tool, but in perhaps different ways than we might immediately think.
Thank you, Paul. To touch upon this very last point that you made, I think it's an open area that should be of intensive research, the identification of, to some extent, patient outliers, patients that do not achieve the best response, but yet may enjoy long-term survival. And I do believe that the time is now for active and intensive research on that area, in case the readout of the ongoing clinical trials push the field towards the direction of acting on positive MRD. either in terms of intensification or prolonging treatment duration. So in that case, you should avoid as much as possible over-treatment, and we should provide the best possible laboratory tools to avoid that over-treatment.
Yeah, I think that's perfectly said, because in D2, for example, for those patients assigned to observation versus IBA, when they go MRD positive, we're deliberately, with the patient focus, saying, if you go MRD positive, you have the option to go back on IBA, provided you're tolerating it well. And we're going to analyze that cohort descriptively, because to your point, there's a lot of anxiety generated amongst our patients around MRD. And I think we have to just be very thoughtful about how we frame that, recognizing it's an incredibly valuable tool, particularly for regulatory and clinical trials purposes. But amongst patients, I'm really struck at how MRD can become a true obsession. And they drive the intensity of maintenance based on single numbers of cells, and counseling them around that and helping them navigate that against the implications of toxicity is in my clinical practice anyway, an evolving challenge, actually.
Thanks. So Bruno, fantastic presentation. I was struck with the MIDAS results, where you showed that the MRD negativity rates for standard and high-risk patients are the same. And so I guess this comes back to that point about what do we call an adequate time point in such patients in order to de-escalate therapy, similar to what Sonja was saying. And I'm with you in terms of improving quality of life and trying to stop therapy perhaps at 2 years with sustained MRD negativity. But I think what would be very useful is in our clinical trials designs to understand what the optimal time point of stopping treatment is in terms of sustained MRD negativity, because I suspect that that is going to change according to the treatments that you've got and the genetic risks. Just today, I was struck, we had a patient who was on one of our very old clinical trials where they received 4 cycles of PAD induction therapy and stopped treatment after that, and has relapsed today, 7 years after that. And who knows what sort of MRD negativity status they've achieved, but clearly just a small amount of treatment was adequate for that patient to enjoy a sustained quality of life. So I guess my point is, I think we need to probably understand quite what level of sustained MRD negativity we need to stop treatment. I don't know if you have any comments.
To start, I fully agree with you. I think that my interpretation of the data coming from the multiple studies that reported on this issue is that survival outcomes are mainly impaired if treatment stops immediately after that MRD negative result, or at least it's only prolonged for 1 additional year. By contrast, in those trials in which the treatment was prolonged for a longer period or eventually until disease progression, the difference in terms of PFS between MRD negative patients, standard and high risk, starts to become smaller. In this particular trial, I do agree that the first readout after 6 induction courses is probably too soon. The trial design relies mainly on the MRD negative outcome rather than the cytogenetics. One positive aspect is that the treatment duration is not immediately affected by the MRD result, it's rather the type of intensification. So hopefully the French group can still obtain positive results from the study.
If I may, just one quick comment to that, Bruno. This duration of MRD negativity, we've really thought hard about, and I think it all critically depends upon the tolerability of the agents you're using, right? I think in the era of lenalidomide, where we always recognize fabulous drug, but lots of challenges, iberdomide, for example, may be a very different story based on some of the early maintenance data. So in D2, for example, we'd landed firmly on 3 years of MRD negativity, to Rakesh's point. But our working hypothesis is that IBA is that going to be that much better tolerated than len, and critically, IBA is going to be associated, we believe, based on strong preclinical data, with a substantially lower risk of second cancer, which is relevant to this discussion as
well. Yeah, that's a good point.
All right, if I may make a comment and ask a question. I think while just to further Sonja's point about high-risk myeloma, where I find MRD most exciting is, ironically, I think it's actually low-risk myeloma, because that's the population you're trying to cure realistically. It would be very interesting to know how long a sustained MRD you need to achieve a real operational cure or a cure in patient with low-risk myeloma, because the prospect of curing high-risk myeloma is much less. And also to that point, I think when we use MRD negativity as an endpoint in clinical trials, it's so difficult to interpret a single time point because what we don't understand is what the tempo of MRD means. So, for example, we find that patients with low risk tend to not achieve an MRD very quick, and they achieve MRD very late. So it depends on where we measure. Just because they don't achieve MRD negativity doesn't mean they don't do well, compared to the high-risk patients who achieve MRD very quick, but they will probably relapse very soon. So to that point, I think that if any studies is going to evaluate or enlighten the role of MRD negativity in terms of treatment decision, we're going to just really have to separate the groups of high risk and low risk in order to interpret.
I couldn't agree more. And honestly, I think of last year, April last year, and the FDA and what was proposed and reached consensus there as a starting point in which you will develop better improved endpoints based on experience, as well as the design of clinical trials looking at specific patient populations. I think that what was proposed there is probably the sum of all. It's a tool to apply in all scenarios, but probably in specific scenarios you can use better tools. And regarding your better definitions and better endpoints, and regarding the first comment, indeed, it is our experience in this, and I'm alluding to the Spanish clinical trials, that patients with a favorable biology, and this can be defined by multiple different ways, but for example, patients with very low amounts of circulating tumor cells, the MGUS-like profile, etc., in whom we make the point that depth of response may be not that important, yet these patients, particularly transplant eligible, when they achieve MRD negative rates, the PFS and OS estimates at 5 and 10 years are very, very promising, around 80%. And I must say that in all these clinical trials, treatment was a fixed duration. So I do think that in this patient population, the MRD negativity sustained over time is not a marker of cure, but is a marker of long-term outcomes, even in the setting of fixed duration.